Good morning. Thank you for joining us for today's webinar, Survey Preparedness F880 and Beyond. I'm Wendy Johnson with the Pennsylvania Healthcare Association. Before we begin, I have a few housekeeping items to cover. PHCA offers monthly webinars to members to receive updates from department staff on regulations, learn from industry experts on current trends and practices, and to gain a better understanding of practical application tools to equip you so that you may continue to provide the highest level of quality care possible. This webinar is being recorded and will be made available on the PHCA website. The webinar has been approved for 1 continuing education credit for PHCA members. Credits will be uploaded to NAB within the next 2 weeks for those who have provided us with your unique NAB number, and I will be sending attendance certificates as well. A survey will be launched at the close of the webinar. Your feedback is important to us and our speakers, so please take a moment to complete the survey. All attendees will be in listen-only mode. However, throughout the presentation, please feel free to submit questions using your questions pane on the right hand of your screen, and our presenter will address them at the end of the presentation. Today's webinar is being presented by Paula Sanders, Principal Chair, Healthcare Practice Group, and Chair, COVID-19 Task Force with Post and Schell. I'll now turn the webinar over to Paula.
Thanks so much, Wendy, and good morning, everybody. I'm going to run through quite a bit because CMS, even though they can't finish the guidance for the requirements of participation phase 3, they continue to mess with our lives in the survey world. So I want to start taking us back a little bit to look at the changes that CMS has made in November to increase the oversight of nursing homes in particular. On the positive side, they've told the states that they no longer need to come out to do focused infection control surveys every time there's been an outbreak. You may remember being inundated with the surveys that were happening 3 to 5 days for those outbreaks. However, the states are still required to prioritize focused infection control surveys for facilities that are reporting new cases and also have low vaccination rates. And that's going to tie in with our discussion later on when we talk about F880 and the vaccine mandates. Additionally, the states are still required to perform annual focused infection control surveys at 20% of all nursing homes in their state in order to qualify for increased federal funding. More troubling, however, is the fact that CMS is trying to account for the backup that's occurred when states were not going out to do complaint surveys and we're spending so much time on focused infection control surveys. So they've actually given states a lot more flexibility to combine revisits with complaint surveys as well as with annual surveys. And that's creating an incredible burden on facilities, and we're just beginning to see that. I will tell you that for those of you who are PHCA members, the American Healthcare Association is meeting with CMS in just a few days, and they have asked members of the legal committee, of which I'm a member, to collect any evidence that we have of the impact of delayed civil money penalties or problems people are having with denials of payment for new admission that are resulting from these changes. So if you do have surveys or anecdotes that you would like either PHCA or me to send to AHCA before the 11th, please get in touch with Gail and Chris at PHCA or send me an email. My contact information will be provided at the end of the webinar so we can try and persuade CMS that these changes are having an enormous negative impact on the facilities. Additionally, because there was such a delay, many nursing homes across the country were well beyond the 15-month recertification schedule. And CMS is now allowing the states to resume recertification surveys by establishing new intervals based on the next survey, not based on the last survey that was conducted prior to the COVID-19 public health emergency. They've also given the states a lot more flexibility. Now remember, we're allowed now to combine multiple complaints in one survey. They've instructed the states to prioritize nursing homes with a history of noncompliance or allegations of noncompliance with abuse or neglect, infection control, violations of transfer or discharge requirements, insufficient staffing or competency, special focus facilities and special focus facility candidates, and or other quality of care issues such as falls and pressure ulcers. They're also supposed to be prioritizing their investigation of complaints and facility reported incidents, or what they call FRIs, that are triaged as immediate jeopardy within 2 working days and non-immediate jeopardy but high complaints and facility reported incidents within 10 working days. If they have other backlog complaints or facility reported incidents at the non-immediate jeopardy medium level, they can hold them until your next until your next scheduled standard survey. So they're not supposed to be coming out on these multiple mid-level type complaints. They're going to hold them all into one survey. And they're going to look at the complaint in most cases within 1 year of the scheduled standard survey date. How far back are we looking? So if it was received in the past year, they'll look at it. However, if the allegation involved staff to resident abuse, neglect, or misappropriation of resident property, they're going to look at it regardless of the date that the complaint was received. So we're seeing this already. People are calling saying, well, we're getting cited for things that happened more than a year ago. And this is why, out of that QSO memo. So I want to raise that to your attention. It's going to be really important to make sure that we're looking at trying to qualify for corrected past noncompliance, which we'll talk about in a minute. Another area that CMS has directed the states to really focus on is staff competency. And what you need to be looking at is what specific documentation you have to show that your staff has the competency in skills and techniques necessary to care for the residents' needs. What are you doing if you're having skills fairs? How are you documenting that? Surveyors are paying special attention to F880. They're instructed to reread those regulations and also to look at the critical element pathway for sufficient nursing staff with appropriate competencies. And we're seeing an increase already in F880 citations. For instance, if there are complaints about the timeliness of responses to call bells, that's now being cited at 726 under the assumption you didn't have sufficient staff, otherwise the call bells would be answered more quickly. The surveyors are also looking for annual performance evaluations and competencies for aides and professional staff, including your PRN and agency folks. And it's an area where it's easy to fix. Consider including your competency checklist when you're onboarding your agency staff. When they're coming in, what are you doing to show that they have the competencies? We've seen people getting cited for LPNs not having a competency that shows they're able to pass medications. If you get cited like that, consider filing independent dispute resolutions, IDRs, because there's got to be some argument you may be able to make that by virtue of checking somebody's license to make sure they're current, which includes their requirement to have continuing education, you're relying on that as a potential way to assure competencies. But it's much easier if you can provide the surveyors with your own documentation to show both of these evaluations are being performed as well as competencies across all levels of staff and regardless of whether they're employed or are contracted. Other heightened areas of concern continue to be antipsychotic medications. The QSO is telling the surveyors to focus efforts on identifying the inappropriate use of antipsychotic medications and emphasize the non-pharmacologic approaches and person-centered care practices. We're still looking for unplanned weight loss, loss of function or mobility, depression, abuse or neglect, as well as pressure ulcers. So those are some of the areas that CMS is focusing on and instructing the staff to look at. Now I want to remind you guys of something else that we're seeing, and this enhanced enforcement under infection control, F880. And this is going to tie in very closely to the new F888 tag. And that's the risk of the denial of payment, the discretionary denial of payment for new admissions. If you're getting cited, and I've included in these slides, which will be available after the webinar, to show you when you could be cited for a DDPNA. And I point this out because Pennsylvania and CMS Region 3 are not giving you a second notice. So if you get hit with an F880 tag for infection control in your letter from the state, you're going to see the imposition of both the directed plan of correction as well as, in most instances, imposition of a discretionary denial of payment for new admissions. You are not going to get another letter from CMS saying in 15 days we are imposing a discretionary denial of payment for new admission. The letter from the state serves as that notice. So pay attention to that, because facilities now are finding themselves, or learning retroactively is a better way to put it, that they've been subject to a denial of payment for new admissions. Now, recall what we just talked about, which is the fact that CMS is allowing the states to delay coming back for revisits. And when they are coming back for revisits, they're often bringing with them a handful of complaints. So even if you think you've corrected the F880 tag, your infection control, you think you're back in substantial compliance, if they come in on a revisit and cite you for non-compliance related to a new complaint, you're still going to continue that denial of payment. So you need to pay attention to that. You may want to start better dialogues with your field office to see if there's any way that they could potentially do a desk review once they get your directed plan of correction. How quickly can they clear you of that so that your DDPNA is not hanging open while other complaint investigations may be taking place? This is just a continuation of the enhanced enforcement for F880. We are trying to work with CMS to present an option that the DDPNA related to F880 should be removed when the facility regains compliance with the infection control deficiencies and not continue for an entire survey cycle. The other thing, for those of you who haven't been paying attention to the inflation increases, every year CMS is supposed to increase the survey CMPs, as do many other agencies. And there are several CMPs and other fines that have been increased by inflation. But I wanted to provide you now with the new increases for 2021, and also to draw your attention to the NATSAP, the Nurse Aid Training Program. The threshold has been increased to $11,000, give or take. Because all of these other sanctions have gone up, more and more facilities are finding themselves subject to the loss of the nurse aid training and competency programs. CMS has so far not shown a lot of willingness to move on this. There is an exception process in PA, as there are in other states, to try and get a waiver. So if you do find yourself subject to the loss of a NATSAP program, you should consider whether or not it's worth approaching the state to get a waiver of the disapproval. But that is the new threshold. Given all of this, it's really important that you try and minimize the risk of the per day CMPs. CMS has revised, or actually removed, one of their QSOs in response to a lawsuit brought by the AARP. AARP had filed suit alleging that CMS was neglecting its duty to enforce sanctions against nursing homes by giving a preference for, per instance, civil penalties for past noncompliance. And now, even if you are able to document corrected past noncompliance, you have a risk of per day civil money penalties. So it's really important, especially now that the state's coming in with multiple complaints. And those complaints could be from your own self-reports, right? If you've got anything that involved patient harm in particular, you really want to implement plans of corrections and document them immediately following that incident. Assess the residents who were involved, remove any alleged perpetrators pending the investigation, make sure you're reporting to all applicable agencies and law enforcement. What are you doing to assess and protect other residents? Educate staff and volunteers if applicable, and ensure they will not work with residents until they have been educated. And this is where we're having a lot of trouble in documenting past noncompliance. For instance, if someone transfers a resident using a Hoyer lift and they transfer by themselves instead of doing a two-person assist, you should have, and maybe it's through Relias or your online training, you should be requiring whole house to get re-educated, not just that individual, because you want to be able to show if the state comes in 8 months later or 10 months later or a year later on that incident, you want to be able to show that you've educated everybody. And that education should include following the care plan, two-person assists, as well as a re-education about abuse and neglect, because often we're seeing facilities getting cited both for F600, which is abuse and neglect, as well as F689, failure to prevent accidents or failure to provide appropriate supervision, or failure to use proper assistive devices. So if you've got a prepackaged, if you will, training that you can roll out, document who is being trained. And if it's a significant issue, you want to have that training done quickly and making sure that folks who aren't there, maybe they're out on FMLA or they're on vacation, that they're not going to work with residents until they've been re-educated. And you've got to have all that documented, implement those corrective measures, and monitor and audit. In addition, you should be reviewing those incidents at your QAPI committee to assess root causes and needed system improvements. One of the things that you may want to consider is putting into your QAPI plan, because the plan is what the surveyors are allowed to look at, right? Does it specify that you can conduct ad hoc meetings to respond immediately to incidents? So a lot of times people will have, they'll discuss these incidents at stand-up or at morning meeting, but there's no documentation that the incident has been reviewed. How do you document the meeting? How are you documenting those? So first we've got to make sure we've pulled it into QAPI. Then we want to make sure we're documenting that the incidents are being analyzed. Was there a physician included in those discussions? Depending on the nature of the incident, you may want to include physician involvement. And what are you reporting to your board of your or your governing body? And then make sure that you're documenting so you can show corrected past noncompliance. Now, in the latest long-term care survey process, the LTCSP procedure guide that just was updated effective last month, January 27th, this is an exact quote from CMS for enforcement considerations. Please note, when imposing an enforcement remedy for past noncompliance, CMS may reach back no further than the last standard survey to do so. This means that a state should not postpone serious complaints that could lead to enforcement and expect to conduct them after the standard recertification survey. So I just want to share that to you because there's all sorts of stuff going on in the survey enforcement that's going to have an impact as well on your F880 infection control compliance, as well as the new vax mandate is F888. And for those of you who are technology challenged as I am, if I hit the shift key while I'm typing the capital F and I keep the shift key down and then hit 888, that's what it comes out as. So I share that with you. I share your frustrations. It's already being enforced and citations have been issued in Pennsylvania. Staff must be vaccinated or granted an exemption or have a temporary delay. Any staff not in these categories will be counted against your compliance rate. We're going to talk about that in greater detail, but first I want to talk about who are staff, right? It's everybody, regardless of their clinical responsibility or patient contact. That includes your employees, licensed practitioners who come in your building, like your dentist, your medical director, your nurse practitioners, individuals who provide care, treatment, or other services for the facility and or its patients under contract or other arrangement, including hospice and dialysis staff, therapists, mental health professionals. It also could include your HVAC contractors if they're in the building a lot, or your painters. It does not include one-off contractors or vendors, such as your elevator contractor. But CMS has not given great guidance on how much contact is necessary to fall into this contractor provision. It also includes adult students, trainees, or volunteers, your administrative staff, your facility leadership, your volunteers or other fiduciary board members who come into the skilled nursing facility, housekeeping and food services. Staff that primarily provide services remotely via telework, but they come in occasionally and occasionally encounter fellow staff, such as in an administrative office or at an off-site staff meeting, who will themselves enter a healthcare facility or site of care for their job responsibilities and others. Now, if the staff exclusively provide telehealth services, or they exclusively provide support services that are provided outside of the facility and they have no direct contact with residents or other staff, they are not included in this vaccination mandate. In general, however, just about anybody who's coming into your skilled nursing facility is going to be subject to the mandate. A lot of folks have said, can I take my non-vaccinated staff and put them in my personal care home, for instance? And that's going to be a fact-specific analysis. If your personal care home is attached to your SNF and staff enter through the SNF to get to the personal care home and they have a potential to be encountering residents or other SNF staff, they're going to fall within that mandate. And the surveyors are going to look to see whether they're vaccinated or not. So it's a broad reaching net. Here's the compliance deadlines. We're already past the first one, which means you have to have policies and procedures both developed and implemented. And to establish substantial compliance, 100% of your staff have to have received at least one dose of the vaccine or have a pending or approved qualifying exemption. It's a religious exemption or a medical exemption, or they have to have received a temporary delay as recommended by the CDC. So that's substantial compliance from now until the end of February. And what does that mean? For purposes of this compliance, fully vaccinated includes the people who have been vaccinated plus you're exempt or pending exempt plus you're delayed. This is not necessarily going to be the same number as your vaccinated staff is showing on your NHSN data. But for compliance purposes, under F880, we're going to look at vaccinated plus exempt. If your vaccination rate is between 80% and you have, or is above 80%, and you have a plan to achieve 100% staff vaccination within 60 days, you're going to be deemed non-compliant. So our threshold right now is, did I hit 80%? If I didn't hit 80% and I have a plan to achieve 100% within 60 days and I have my policies and procedures, I'm still going to get cited, but I'm not going to have an enforcement remedy applied against me. In 60 days from the date that the regulation became effective, or on February 28th, we're going to look to determine what our vaccination rate is. If my vax rate is above 90%, and I now have a plan to achieve 100% staff vaccination within 30 days, I'm still non-compliant, but I'm not going to have an enforcement remedy imposed against me as long as I've got the policies and procedures in place. By March 28th, I've got to be fully vaccinated or I've got to have the remaining staff have an approved qualifying exemption or a temporary delay. So there's was some confusion about this non-compliance but no enforcement level. And some folks have been cited because they are above 80%, but they didn't hit 100%. So anything between 100 and 80 right now is considered to be non-compliant. Recognizing, however, if you include your exempt people, you may be able to hit that 100%. And that's what the surveyor should be looking at, is jabs plus exemptions plus temporary delays. They're going to be looking for your process or plan for vaccinating all eligible staff, as well as your process or plan for providing exemptions and accommodations, which we'll talk about in a minute. A process or plan for tracking and documenting the vaccinations, including booster doses, contraindications, exemptions, and temporary delays. A process for ensuring the implementation of additional precautions intended to mitigate the transmission and spread of COVID-19 for all staff who are not fully vaccinated. And that includes, for this purpose of not fully vaccinated, your exempt folks. And Pennsylvania has so far taken a position contrary to the express language of the regulation and the express language of the guidance, and they are citing people who are allowing exempt staff to provide direct patient care. We're working very closely trying to get the department to reverse their position. The last we heard, they were still waiting for further guidance from CMS. As far as I have been able to determine, Pennsylvania is the only state who is taking the list of potential mitigating factors and saying they are each mandatory. So for instance, one facility is being cited because even though the exempt staff were wearing additional PPE, they were not social distanced from the residents. Now, obviously, you can't be social distanced from a resident when you're providing care, but that was the position that the surveyors have taken. You also need to have in place a contingency plan for staff who are not fully vaccinated for COVID-19. You want to look at the elements. I would pull up the QSO guidance because it gives you some examples of what the surveyors are going to be looking for in your contingency plan, including the prioritization contingency plans for staff who have no shots over staff who have one shot. Include deadlines to obtain the first dose and actions you will take if the deadlines aren't met, such as actively seeking replacement staff or obtaining temporarily vaccinated staff. Now, if your policy says we are going to give staff 2 weeks to get vaccinated and we're going to put them on temporary leave, if you're subject to survey in this period, those unvaccinated staff are going to be counted against your compliance rate. In other words, if you had terminated them and said, well, we'll rehire you if you get vaccinated or if you provide a request for an exemption, remember those pending exemptions in this period allow you to include them to hit your 100%. But if you have staff right now who are neither vaccinated nor indicating that they're wanting to apply for a exemption, you may want to talk with your employment counsel and take separation considerations into effect to avoid a citation under here. These next two slides I'm providing for you is pretty much just a cut and paste from the regulation, but I wanted to draw your attention to this third item. These are the process for ensuring the additional precautions to mitigate the transmission and spread of COVID for all staff who are not fully vaccinated, right? The first one, see, it says this might include, it doesn't say this must include. It might include reassigning staff to non-patient care areas, to duties that can be performed remotely, i.e. telework, or to duties which limit exposure to those most at risk. For example, assigning your exempt staff to residents who are not immunocompromised or unvaccinated. It does not say you must do that. However, when the surveyors come in, one of the questions they're going to be asking staff who are exempt is whether or not they were reassigned. Another thing that you could consider is requiring staff to follow additional CDC recommended precautions, such as adhering to universal source control and physical distancing measures in areas that are restricted from patient access. For example, staff meeting rooms and kitchens, even if the facility or service site is located in a county with low to moderate community transmission. Well, again, what we're looking at here says physical distancing measures in areas that are restricted from patient access. It does not say staff who are exempt have to physically distance from residents. However, that is the interpretation that we are hearing from a couple different field offices right now. Another additional precaution is requiring at least weekly testing for exempted staff and staff who have not completed their primary vaccination series until the regulatory requirement is met, regardless of where you're located, in addition to following CDC recommendations for testing unvaccinated staff in facilities located in counties with substantial to high community transmission. The third one, or the fourth potential, and you could come up with other ones as well, is requiring staff to use a NIOSH approved N95 or equivalent or higher level respirator for source control, regardless of whether they are providing direct care to or otherwise interacting with patients. So I would recommend that your policy certainly include all of these as options, and whatever it is that you decide to do for individuals on a case-by-case basis, that there is a signed acknowledgement from that individual that they acknowledge that they're responsible for following these additional precautions, and that the failure to do so will subject them to discipline up to and including termination. And I say that because, well, there have been many people who have legitimately held religious beliefs, sincerely held religious beliefs, and there are others who have legitimate medical exemptions. There is a subset of staff who have filed requests for religious exemptions that may not necessarily be sincerely held. They may not think COVID is real. They may not believe in the vaccinations, whatever it is. These folks are your low-hanging fruit and your largest risk, because their failure to follow your precautions will subject you to citations, and the citations may not be under F888, right? Because under F888, I'm okay if I hit 100%, combining my folks who are vaccinated plus my folks who have exemptions. But I'm going to be subject to an F880 tag potentially, which could be at an immediate jeopardy level, depending on what the staff person has done and what the degree of risk is with respect to resident outbreaks of COVID. You want to take a look at these two pages. People have asked what should be on my proof of vaccination. How do I know that we've got the right thing? Obviously, you want to have the employee's name, the type of vaccine administered, the dates of administration, and the name of the healthcare professionals or clinic sites that administered the vaccine. There are a number of different kinds of acceptable proof of vaccination, including, the normal cards. You may want to take a look at this if you do have questions about whether or not you're looking at acceptable proof. Now we get to the real difficult question. What about contractors and vendors? How are you going to prove to the surveyors that your folks are complying with the QSO and with the regulations? Many people are amending their contracts to require some of these things that you might want to consider. You're only going to send me vaccinated staff. You're going to give me an attestation, vendor, that you're only going to give me vaccinated staff. CMS has not said that they will accept an attestation in lieu of proof of vaccination. You may also want to include a provision in your contracts that says, okay, in addition to giving me an attestation that you're only going to give me vaccinated staff, you're going to give me proof of vaccination within an hour of my request. And you would need to do that, obviously, if the surveyors are in the building. Right now, testing is not an option. You can't say, okay, I don't have proof from my transport vendor that they're vaccinated, so instead I'm going to test them before they come in. That's not an option. If that vendor gets picked during a survey, you need to be able to show what you've done to obtain that proof of vaccination. CMS is supposedly going to look for good faith efforts. So I would make sure you're documenting all of your outreach to all of your vendors. If you have therapy vendors who are in-house every day or hospice that's in all the time, you may find it just easier to include them in your process and obtain their vaccination proof so that you have it on file for them. What about exempted contractors, vendors, or volunteers? That's a wide open question. The volunteers is probably a little bit easier for you to control because they're your own. But what if your contracted therapy company says, well, Paula's got an exemption and we've approved it? Then you have to make your determination. Are you going to accept an unvaccinated exempted person who didn't go through your exemption process? And then what mitigation efforts are you using for that individual? So a lot of things we're still waiting on CMS to come out with a little bit more guidance. For the religious exemptions, this falls under both Title VII on the federal side and the Pennsylvania Human Relations Act. You are allowed, and staff should be able to request religious exemptions, and there's a presumption that they're based on sincerely held religious beliefs. The EEOC has said that the fact that no religious group espouses these beliefs, or the fact that the religious group to which the individual professes to belong may not accept such a belief, doesn't determine whether the belief is the religious belief of the employee or prospective employee. And basically what that says is You got to take each one on its own face, right? You can't ask for clergy signatures, letters. If there's an objective basis for questioning the religious nature of the sincerity, you may request additional factual supporting information, but you cannot say, if you don't give me a letter from your pastor, I'm not going to grant you a religious exemption. Now, if the religious exemption request comes in and says, I object to it because this is a conspiracy and it's going to implant microchips, that's not a religious exemption, right? The objection can't be based on social, political, or personal preferences or other non-religious concerns. They have to be religiously based for you to grant the religious exemption. Now, the surveyors are going to look at your policies and procedures and ask your staff about them. And you need to have them, but the surveyors are not supposed to review the underlying requests for the religious exemptions. They're just supposed to look for your policies and procedures with respect to that. They are, however, going to look very carefully at the requests for medical exemptions to make sure that all of the elements required by the regulations are on those forms. And if you go back to the regulations on slide 17, you will see the information that needs to be provided for medical exemptions. I'm not going to go through and read them for you right now because I do have some other things to cover with you. CMS has provided the staff matrix that the surveyors are going to be using when they come into your facility. You'll have 4 hours to complete this. I would suggest that if you're not using this form, you might want to make sure your information and the way you are keeping them for vaccination status is easily translatable into this material. So it's a picture of it, but what I want to show you more specifically is we're looking both at direct facility hires, C, the contracted hires, O is the other, the adult students, trainees, and volunteers. A lot of facilities are gathering information like that, but they're not necessarily recording the person's assigned work area. And that's the physical location. Where are they? Are they in the laundry room? Are they in the kitchen? If the staff person is a PRN, a floater, or agency, they're going to want to know where that person is assigned on the first day of the survey. They're also, when they're totaling up your staff, they're going to look at all employees, regardless of the clinical responsibilities or resident contact, as well as the other folks that we've just talked about. So when you're compiling your vaccination status, this matrix will be a really good thing to look at to make sure if you don't have all of the information that the surveyors are going to be looking for, that you start grabbing that now. Additionally, the surveyor task for F880 is going to include the infection prevention and control program, the policies and procedures for staff COVID vaccination, antibiotic stewardship, flu, pneumococcal, and COVID-19 vaccines for residents and staff. You've got 4 hours to do the matrix. And once the matrix is given to the surveyors, the assigned surveyor is going to pick 8 staff to review for COVID-19 vaccination. They're going to pick 2 vaccinated staff, at least one of whom is going to be an aide, and another one who is going to be a contractor. They're going to look at 6 unvaccinated staff if they're available, 3 unvaccinated staff, 2 CNAs who don't have an exemption or a reason for a temporary delay, They're going to look at one non-medical exemption, which would be somebody with a religious exemption, for example, and one medical exemption. And if there are 2 or more staff with medical exemptions, they're going to select 50% of the staff from those categories, and one person whose primary vaccine series has been temporarily delayed. Additionally, they are allowed to add any staff who aren't vaccinated and weren't granted an exemption or temporary stay, and you didn't provide on the staff matrix. And these are the folks you're going to be talking to, about not just your vaccines, but about your infection control processes. And they're the ones that are going to be followed with big targets on their back to see and to make sure they're following whatever mitigation steps you've put in place. I just want to go over, these levels now for immediate jeopardy. Under F880, if you didn't have the right number of staff vaccinated or no policies or procedures, and you had 3 or more resident infections in the last 4 weeks, that's our look back period, resulting in at least 1 resident hospitalization or death. So that would be immediate jeopardy. Another example, non-compliance with the likelihood for serious harm or death. You didn't have enough staff vaccinated, and you had 3 or more residents infected, and the surveyors observed non-compliant infection control practices, or you didn't have all of your components of your policies and procedures implemented, or more than 40% of your staff are unvaccinated and there's a lack of evidence. So it could be any one of a number of things here putting you in immediate jeopardy. Level 3, actual harm that is not IJ. That should be an I and a J, pretend. You didn't meet the requirement of staff vaccinated, and you had 3 or more infections in the last 4 weeks, which did not result in hospitalization or the likelihood of IJ for 1 or more residents, and 1 or more components of the policies and procedures were not developed and implemented. Level 2, this is no actual harm with the potential for more than minimal harm that is not IJ. You didn't have the requirement of staff vaccination, and there were no resident outbreaks, or you didn't meet the requirement of staff vaccination and 1 or more components of the procedures were not developed. So that's going to be your D, E, or F. Level 1 is going to be always a widespread C. You have the requirements of having all your staff vaccinated, and 1 or more components of your policies and procedures were not developed and implemented properly. Scope, isolated, you've got 1% or more, but less than 25% of staff are unvaccinated. A pattern, and then here's the information for widespread. Note that once we get to widespread, that's how they got to the C. If you have 1 or more components of your policies and procedures were not developed and implemented. Questions we're getting a lot, can we test visitors? CMS has moved their position and said you can test visitors now, but only if you have the ability to do rapid tests in-house. You cannot require visitors to give you proof of vaccination, and you cannot require visitors to give test results if you do not provide the testing. However, your residents can tell you, and you can care plan if they want to restrict their own visitors to those who are vaccinated or tested, and the resident wants you to have the proof of those. So there are ways, if you can talk to some of your residents, if you're unable to do the rapid tests in-house, where you may be able to care plan, because this would be driven by resident rights. And finally, I know we're hitting up on the 11 o'clock hour here. CMS is expected to additional guidance. Stay tuned. I would urge you to stay in close contact with Gail and Chris at PHCA if you're experiencing problems, so that these can be communicated either up to the state or through the American Healthcare Association and on to CMS. I would urge you to up your game with respect to responding and documenting quickly to incidents within your facility. And more than ever, I would be filing IDRs and IIDRs to challenge, because I think the surveyors are getting a lot wrong. The stakes are really high given the denials of payment for new admission, as well as the increased civil money penalties. So you really need to be taking a more aggressive approach to managing your own survey process. And with that, Wendy, I'll turn it over to you for some questions if folks want to stay around.
Great. Thanks, Paula. We do have some questions that have come in, and we are open to a couple questions. We will address as many as we can. Let me start with the first one. Surveyor in the facility today and stated that they were told that any complaint will also trigger an infection control survey.
So when they are coming out, they're supposed to now be doing infection control as well as the F880 tasks. So that's probably is a true statement.
Okay. Can you elaborate more on staff competencies, documentation, etc., particularly for TNA, for temporary nurse aides?
I would document if they're going through a Reliance, an online training, but also if there are certain tasks. Most places have those little competency checklist forms, right, where somebody is being onboarded and they're being observed as their ability to do the task that they're being assigned to do. And you should have separate competency checklists for the trainers to observe and record. And I would make sure they're being done at least annually.
Okay, we have a couple more questions. We'll try to get these two in, and then if there are more questions, please feel free to be in touch and we will get those answered for you. What about new staff and the vaccination mandate?
So new staff in this period, as long as they're coming in and they have the first vaccine, they'll qualify, or if you're granting them an exemption or that exemption is pending. But new staff are included. They're expected to be vaccinated. Some folks are rewriting their job descriptions to make this a condition of employment, right? That you have to be vaccinated. Recognizing, however, that if somebody has a legitimately held sincerely held religious belief or a medical exemption, you may need to grant those so that you're not violating the Americans with Disabilities Act or the or Title VII. So it gets a little bit more complicated in terms of how you're going to be enforcing that vaccine mandate as a condition of hire, because you still want to be able to grant medical and religious exemptions. We didn't spend a lot of time talking about that. There are hardship elements that you may be able to demonstrate as to why it would be a hardship not to grant those accommodations. A lot will depend as well on the job descriptions and responsibilities for the specific applicants that you're considering.
Okay, we do have another question about religious exemptions. Do religious exemptions need to be listed as declined on NHSN? There is no religious exemption section.
I don't know the answer to that, Wendy. I have not looked at the new revisions to NHSN. So we'd have to get back to the questioner about that.
Okay, we can certainly put that. I'll flag that one. And one last question. Are we required to have the documentation from contracted exempt staff, i.e. religious, or is providing the approval letter from the contracting company along with our documentation of the accommodations we require enough?
It should be. And I say that because we haven't seen how this Pennsylvania surveyors are interpreting what they're looking for with respect to the contractors. But if your policy says we're recognizing the exemptions granted by our contractors, and that's in your contract, or if other documentation as between you and the contractor, that you should be able to show that good faith attempt to make sure everyone who's coming in is vaccinated. They should, as long as they're following your mitigation strategies for those folks, that should be okay. But I can't tell you definitively that the state's going to agree with us, since right now they're not even agreeing with the express language of the regulation.
Okay. We do have a couple more questions, but I will handle those. We'll handle those internally, and if we need to get Paula involved in answering them, we will. And again, if we need to do an FAQ document, we'll certainly look at that as well. But we do need to wrap up since it is past our hour allotment here. We want to give everybody some time back in your day to get back to resident care and other things that you need to do. So thank you. All this information that you've shared with us, Paula, the handout will be sent in a follow-up email. And again, today's webinar is being recorded. If there's anyone out there that you think could benefit from it, please send them to our website. I'll have that up on the website today or tomorrow. Again, check, we do have webinars scheduled into March, so please keep an eye out for those. And Paula, thank you again. This is a lot of information. We'll continue to keep everyone up to date as things are changing rapidly. Just want to wish everybody a great remainder to your day, and stay well, everybody.
Thanks, everybody. Bye-bye.